Peace, peace. Welcome to the YouTube live book reading of Clinical Application and Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Neville Riley. Welcome, YouTube. Peace. Welcome. Yes. We go into chapter 4 today. I wish you are all having a wonderful, wonderful, lightful rest. I wanted to be ready for this, to give you this peace. Live from the light. We pick up at page 87, chapter 4. Physiology of external respiration. This is good. Peace, YouTube. Welcome to the live book reading. Physiology of external respiration. The foundation of animal life is cellular metabolism. This metabolic system is dependent upon simple gas diffusion for its continuance, i.e., a continual supply of oxygen and a continuous removal of carbon dioxide. All organ systems depend upon the process of homeostasis for proper functioning. Homeostatic mechanisms invoke feedback systems that alter cellular and organ system function to maintain physiologic normacy. Cardiopulmonary homeostasis involves the interrelationship and complexities of the pulmonary, cardiac, vascular, and blood systems, all for one purpose: appropriate gas exchange. The respiratory care practitioner must be concerned with the multiplicity of factors involved in oxygen and carbon dioxide exchange across all permeable membranes. A clear and concise understanding of these processes is essential to the application of proper respiratory care. The fundamental precept is that there are two distinct capillary beds where gas exchange takes place: systemic and pulmonary. Peace, peace, highest heart love, Jorge. Welcome to the part of YouTube that's peaceful. We read books and learn from masters. Thank you so much. The systemic capillary bed. This is preparing people for the MCAT, the next generation. The systemic capillary bed is commonly referred to as the microcirculation and is composed of the vasculature between the systemic arterial and venous systems. These capillary beds provide the vehicle for gas exchange and nutrient supply for all cells except alveolar epithelium, respiratory bronchioles, alveolar ducts, and alveoli. Gas exchange across systemic capillaries is referred to as internal respiration, exchange between blood and tissue. Clinically, the measurements of these gas exchange is referred to as the respiratory quotient, RQ, the volume of carbon dioxide produced compared with the amount of oxygen consumed per unit time. RQ equals VCO2 over VO2. In the normal 70 kilograms, 150-pound man or woman, approximately 200 milliliters of carbon dioxide is produced per minute, while approximately 250 milliliters of oxygen is consumed. Using these numbers, the calculation of the respiratory quotient then becomes 200 milliliters of CO2 divided by 250 milliliters of O2, which is equal to zero point 0.8. This relationship is assumed to be valid if all metabolism is taking place in the normal aerobic Krebs cycle and the patient is at a basal resting or steady state condition. Page 88. Peace, peace. Thank you, highest heart love. The ventilation perfusion relationship. We're preparing the next generation for the MCAT. We read books and stay in peace and harmony on this part of YouTube. Thank you so much for being here. Page 88. The ventilation perfusion relationship. Gas exchange between blood and the external environment occurs in the pulmonary capillary bed, a process called external respiration. The quantities of carbon dioxide and oxygen exchange must logically equal the exchange in the systemic capillaries. Oxygen being added to the blood while carbon dioxide is being removed. This relationship of volumes of carbon dioxide and oxygen exchange per minute by the lungs is the respiratory exchange ratio, the RR. The respiratory exchange ratio represents the overall exchange capability of the lung, Mhm. not individual variances occurring within different parts of the lung. The most efficient gas exchange would occur if there existed a perfect match between all lung ventilation and all pulmonary capillary blood flow. Theoretically, this would necessitate a lung constricted in such a way that a single large alveolar surface communicated directly with the atmosphere. All gas moving into such a lung would become into immediate contact with the alveolar surface. Additionally, it would be necessary to have a single capillary surface in immediate contact with the single alveolar surface. Presumably, all the blood passing through the single capillary would come in equal contact with the alveolar surface. Peace, highest heart love. Thank you so much for reading. Medical book for the people. Clinical respiratory, yeah, clinical application of respiratory care. Thank you. Thank you so much for being here and reading books with us, all the book lovers community. Highest heart love. This ideal circumstance is impossible in man because the pulmonary system is constructed as the valvulus to and fro pump, necessitating a series of tubular structures through which gas must travel to reach the alveolar surface. Therefore, only a portion of the total ventilation comes into contact with the alveolar surface. The ventilation reaching the alveoli and having molecular exchange with blood is referred to as alveolar ventilation. Physiologically effective ventilation. Using the example of our normal 70 kilogram, 150-pound man, the minute ventilation, total ventilation in 1 minute could be approximated at 7 liters compared with a cardiac output of 5 liters in the same minute. At best, only 5 of the 7 liters can be alveolar ventilation. At the least, 2 liters must be physiologically wasted, or dead space ventilation. A further characteristic of the pulmonary system that makes it less than ideal is that both gas and blood are affected by gravity. Therefore, dependent portions of the lung for an upright patient, the base of the lung, will receive a greater portion of the ventilation and perfusion. However, because of the greater density of blood with respect to air, a mismatch of the ventilation perfusion relationship is created, i.e., in the gravity dependent portion of the lung, the blood flow exceeds the airflow. Bing! Deep, right? Thank you so much for reading with us. We connect the dots here on this peaceful part of YouTube where we read books and learn from masters. Honor you. Thank you so much. On the other hand, in the non gravity dependent portion of the lung, the airflow exceeds the blood flow. The mismatch between ventilation and perfusion is the further complicated when areas in the lung exist where there is perfusion without ventilation, and where there is ventilation without perfusion. These two abnormal conditions are categorized under the concept of shunting and dead space. An alternative method of expressing the effectiveness of pulmonary gas exchange is to consider the matching of ventilation and perfusion, or more precisely, the relationship between the volume of gas moving into an alveolus and the blood flow through the adjacent capillary. The advantage of this approach is that it takes into account the efficiency of molecular gas exchange in all areas of the lung. It is difficult to fully comprehend the complex ventilation to perfusion relationship. However, a basic understanding of the concept is essential. We're at the middle of page 89. Thank you so much for reading with us. Welcome, YouTube. Hi, it's Heart Love. Yes. Peace, peace. Gravity. This is awesome. Right? I know. This is the highest level. This is what we do it for. Not everyone has the ability to have a $3,500 book. So we come to this peaceful part of YouTube and we give the information away for free. So thank you for liking and subbing. We're moving toward 500. This is big time information. You know, um, I'm so honored to be able to bring it to you and read it to you because I have the vocabulary to actually do it. Whereas, people don't have the experience. So I help bring them into it. That's what masters do, right? Masters are always mastering. So we want to master thyself. And that's the ideal reason I read all of this information to the people. It's knowledge of self. Master thyself. Gravity. Yes. In normal man standing erect, there is a distance of approximately 30 centimeters from the apex top to the base bottom of the lung. Assuming the pulmonary artery enters the lung halfway between top and bottom, the pulmonary artery pressure would have to be great enough to overcome a gravitational force of 15 centimeters of water in order to supply flow to the apex. A similar gradient would be aiding flow to the lung base. A column of blood, essentially H2O, 15 centimeters high, exerts a pressure of approximately 11 millimeters Hg. This gravitational effect on blood flow results in a lateral wall pulmonary artery pressure at the lung base, greater magnitude than the pulmonary artery pressure at the apex. Thus, blood will perf- preferentially flow through the gravity dependent areas of the lung. Figure 4.1. Under normal circumstances, alveolar pressures are equal throughout the lung. Theoretically, the least gravity dependent areas of the lung, the apex, in the upright subject, may have alveolar pressures higher than the pulmonary arterial pressures at that level. This would result in a virtual absence of blood flow to these areas. It should be noted that the total absence of pulmonary blood flow to these areas does not exist to any significant extent in the normally perfused lung. However, if pulmonary artery pressure is significantly decreased, e.g., shock, or alveolar pressure is significantly increased, e.g., intermittent intermittent positive pressure breathing, or positive and expiratory pressures, the absence of perfusion to the least gravity dependent areas of the lung may become significant. This is so big. Okay, so here you go. Here's figure 4.1, page 90. And it has A, B, and C showing in different positions of the lung. All right, it says figure 4.1. I'll show you. Thank you so much for reading with us. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition. Yes, yes, expensive information like this we give for free. That's what Lightworkers do. Thank you so much. It says 4.1. The preponderance of pulmonary blood flow will normally occur in the gravity dependent areas of the lung. Thus, body position has a significant effect on the distribution of pulmonary blood flow, as shown in the erect, A, supine, lying on the back, B, and lateral, lying on the side, C positions. From Shapiro, B.A. Harrison, R.A., and Walton, J.R., Clinical Application of Blood Gases, Second Edition, Chicago, Yearbook Medical Publishers, 1977. The three-zone model. Top of page 91. It has become well accepted to refer to the gravity effects of pulmonary perfusion in terms of the three-zone model. Figure 4.2. Zone 3 is the gravity-dependent area of constant blood flow, arterial pressure greater than alveolar pressure. Zone 1 is the least gravity-dependent area of potentially no blood flow, alveolar pressure greater than the arterial pressure. The interceding area is zone 2, an area of complex and varying intermittent blood flow. The presence of or absence of blood flow in zone 2 depends primarily on the relationship of pulmonary arterial pressure to alveolar pressure. Under normal circumstances, this is determined far more by the cardiac cycle, systole and diastole, than by the ventilatory cycle, inspiration and expiration. So here's figure 4.2, and it shows the no flow zone, intermittent flow zone 2, constant flow zone 3. Gratitude and highest heart love. Clinical application of respiratory care. Second edition by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. All right. Says figure 4.2. The three-zone model illustrating the effects of gravity on pulmonary perfusion. See text. From Shapiro, B.A., Harrison, R.A., and Walton, J.R. Clinical Application of Blood Gases, Second Edition, Chicago Yearbook, Medical Publishers, Inc., 1977. Cardiac output. Middle of page 91. The amount of blood injected by the right ventricle per unit time, cardiac output, is a major determinant of blood flow through the pulmonary vasculature. In general, the greater the cardiac output, the greater the pulmonary artery pressure. Thus, in the normal lung, as the cardiac output increases, zone 3 extends upward. See figure 4.2, which we just looked at. Conversely, as the cardiac output decreases, zone 3 descends. Since the pulmonary vascular system tends to react passively to changes in arterial pressure, the gravity effect on the distribution of blood flow secondary to cardiac output changes in greater in the pulmonary system than in the systemic circulation. Middle of page 92. Regional differences in ventilation. This is very key. So awesome. Thank you so much. We're reading a masterful book about respiratory care and how to give it and how to receive it. Right? Regional differences in ventilation. In normal man standing erect, intrapleural pressure is more subatmospheric at the apex than at the base. Figure 4.3. The most probable reason for this is that the lung is suspended from the hilus, and the weight of the lung requires a larger pressure for support below the hilus than above. Thus, pressure near the base is greater, and thereby the intrapleural negativity is less. This phenomenon is completely gravity dependent. Approximately one half of the total lung capacity remains in the lung at the end of expiration, i.e., normal FRC is approximately one half the normal TLC, total lung capacity. The distribution of this lung volume will be primarily a function of the transpulmonary pressure, TPP, which is greater at the apex than at the base. See figure 4.3. Here's figure 4-3, and it shows at the top plus 10, in the middle plus 5, and the bottom plus 2. And then intrapleural pressure, -10 at the top, -5 in the middle, and -2 in the intrapleural pressure at the bottom. And then it shows the IRV, VC, VT, the ERV, FRC, and the RV. Okay, here we go. Transpulmonary pressure and the total lung capacity and normal lung volumes. Thank you so much. Being honorable. Highest heart love. Everyone in the Imbangi, like Dr. Carr likes to say, thank you so much. Clinical application of respiratory care, second edition. Okay, so you see, looking at the total lung capacity in different volumes. Okay, so I'll read. It says, Figure 4-3. The bar graph depicts normal total lung capacity and normal lung volumes. RV equals residual volume. ERV equals expiratory reserve volume. VT equals tidal volume. IRV equals inspiratory reserve volume. And VC equals vital capacity. FRC equals functional residual capacity. The lung diagram represents the erect lung and the pleural space at FRC. Airway pressure and all alveolar pressures are zero. That's atmospheric. Interpleural pressures are negative to the greater degree at the apex than at the base. See the text. The numbers are for illustrative purposes and do not necessarily represent actual physiologic measurement. Note that the transpulmonary pressure, airway opening pressure minus intrapleural pressure, is greater at the apex than at the base. This is the primary reason why the alveoli are larger at the apex and smaller at the base of the lung, which would make sense, right? Because we already talked about that. It's where the opening is. So the opening for the lung is in the air. See where it says the airway pressure. Okay. See? So that's where it's opening up. So that's where the transpulmonary pressure is going to be greater. Makes sense, right? Thank you so much. Highest heart love. Welcome for reading doctor books with us, right? This is the peaceful place where we can do that, right? So thank you so much for being here. Highest heart love. Alveolar volumes are greater at the apex due to the greater TPP. In fact, they are so large that they lie on a part of the compliance curve, whose slope represents a lesser compliance than do the basilar alveoli. See figure 24.3. Thus, during inspiration, the inspired gas will tend to go toward the bases because the basilar alveoli are easier to inflate than the apical alveoli. Regional differences in ventilation refer to volume changes in relation to resting volume. Compared to the apex, the base of the lung has a smaller resting volume and undergoes a larger volume change per unit of lung. Therefore, basilar ventilation is greater. This will hold true for dependent lung in any body position. In general, as an expiratory volume, FRC increases, apical ventilation decreases. As FRC decreases, apical ventilation increases. So good, right? I love this life. This is playing a part, big time, preparing the youth with great information, right? We're doing it. Another book. You can go down the whole list on this YouTube channel. That's what we do. Read books and learn from masters. And we manifested this together. A $3,500 book to read and prepare the youth. Thank you so much. We're at the middle of page 93 of chapter 4, physiology of external respiration. Eyes on shunting and dead space. The basic pulmonary gas exchange unit is composed of a single alveolus with its associated pulmonary capillary. This theoretical respiratory unit can exist in one of four relationships. Figure 4.4. 1. The normal unit is one in which both ventilation and perfusion are relatively equal. 2. A dead space unit is one in which the alveolus is normally ventilated, but there is no blood flow through the capillary. The alveolar gas cannot participate in molecular blood gas exchange. Or 3. A shunt unit is one in which the alveolus is completely unventilated, while the adjacent capillary has blood flow. The blood goes from the right to the left heart without undergoing gas exchange. And 4. A silent unit is one in which both the alveolus and capillary are completely collapsed. Any one of these absolute conditions may exist in the lungs at any time. It takes little imagination to appreciate that an infinite number of ventilation perfusion relationships may exist between the dead space unit, the normal unit, and the shunt unit. This spectrum is illustrated in Figure 4.5. The complexities of the ventilation perfusion ratio are primarily due to the spectrum between the two extremes of dead space and shunt. This is so good, right? I know. Thank you so much for reading books with us. Hi, it's Heart Love. All right, so this is figure 4.4, and then I will show you figure 4.5 on page 94 and 95. So 4.4 first shows the normal unit in A, and B, the dead space unit, C, the shunt unit, and D, the silent unit. Let me just discuss. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Thank you so much for reading with us. It says Figure 4.4. The theoretic respiratory unit. A. Normal ventilation, normal perfusion. B. Normal ventilation, no perfusion. C. No ventilation, normal perfusion. D. No ventilation, no perfusion. From Shapiro, B.A., Harrison, R.A., and Walton, J.R., Clinical Application of Blood Gases, 2nd edition, Chicago, Yearbook, Medical Publishers, 1977. All right. And here's figure 4.5, showing the spectrum of ventilation to perfusion relationships. So it has the dead space unit going through A to normal unit and then to the shunt unit. Okay. Thank you so much for being here. The top of page 94. We got it. There you go. Should be a little better. Thank you so much for being here and reading with us. MCAT material, high level, mastery level reading, vocabulary off the charts. I love it. Thank you so much. That's what we do here. That's what us light workers do, right? Okay. So it says figure 4-5. The spectrum of ventilation to perfusion relationships. As shown, A represents the spectrum of ventilation in excess of perfusion. B represents the spectrum of perfusion in excess of ventilation. The true dead space unit is represented as infinite. V A over Q. The normal unit is represented as VA over Q equaling 1. The shunt unit is represented as 0, VA over Q. The concept of physiologic dead space. This is the key. This is very key. Thank you so much. Oof, this is big. Let's breathe. Breathe with me. Come on. It's okay. I know it's a lot. That's why I put it in the playlist so you guys can take notes, for those that will be taking tests on it. So I love you. That's why I do this work. I love myself. You can tell. That's what makes me able to be able to grab from that ability of love and share. The concept of physiologic dead space. Further clarification of the dead space concept is necessary to appreciate its clinical importance. The physiologic dead space is defined as that portion of the total ventilation that does not exchange with pulmonary capillary blood. This has been previously described as wasted ventilation. Physiologic dead space can be divided into anatomic and alveolar components. Anatomic dead space is that portion of the total ventilation that occupies the space within the tracheobronchial tree. Alveolar capillary gate gas exchange is impossible since the gas never reaches alveolar epithelium. As a general rule, the anatomic dead space is equal to 1 milliliter per pound of ideal body weight. Alveolar dead space is that portion of the total ventilation that contacts alveolar epithelium without blood flow. This portion of the dead space ventilation has the potential for exchange, but it is not exchanging because of some physiologic or pathophysiologic condition curtailing pulmonary blood flow. The gas moving in and out of these alveolar areas is as wasted as gas occupying the tracheobronchial tree. Using our previously developed concept of ventilation to perfusion inequity, some alveoli can be shown to have gas exchange significantly in excess of the blood flow through the respective capillaries. Some of this gas may not exchange with blood and will be dead space ventilation. The total ventilation must be composed of two portions. One, dead space ventilation, that portion which does not exchange with pulmonary blood. And two, alveolar ventilation, that portion which physiologically exchanges with pulmonary blood. Since alveolar ventilation is effective ventilation, it is the only portion of the total ventilation essential to the life support of the organism. Thank you so much for being here and reading books. This is what we do. This is what we do. It's for the people. Top of page 96, chapter 4. We just started chapter 4 in this reading. The concept of physiologic shunt. A common cause of hypoxemia is a disease that produces intrapulmonary shunting. The physiologic or total shunt is that portion of the cardiac output that does not exchange with alveolar air. The physiologic shunt has been subdivided into three components. 1. The anatomic shunt. 2. The capillary shunt. And 3. Shunt effect, perfusion in excess of ventilation, or V over Q inequality. Anatomic shunt. In the normal person, approximately 2 to 5% of the cardiac output is returned to the left heart without entering the pulmonary vasculature. The blood flow is via the bronchial pleural and the thespian veins. In addition to this normal anatomic shunt, pathologic anatomic shunts can exist, e.g., vascular lung tumors and right to left intracardiac shunts. Capillary shunt. Blood entering a pulmonary capillary that is coupled with an unventilated alveolus returns to the left heart without gaining oxygen. In other words, the capillary shunting is a result of pulmonary capillary blood in contact with totally unventilated alveoli. The sum of the anatomic and capillary shunts is frequently called the true or absolute shunt. This absolute shunt may be refractory to manipulation of oxygen therapy. See chapter 7. Shunt effect. This physiologic defect is often referred to as V over Q inequality or perfusion in excess of ventilation. It occurs in the alveolar capillary unit that has either a poorly ventilated alveolus or an excessive rate of blood flow. Blood leaving this unit has a lower oxygen content than blood leaving a normal alveolar capillary unit. This shunting secondary to ventilation perfusion inequity is the extremely complex and variable component of the physiologic shunt. Its clinical importance is that it is responsive to oxygen therapy. That is, small increases in inspired oxygen concentration frequently result in dramatic increases in the amount of oxygen carried by the blood. See chapter 7. A change in the characteristic of the alveolar capillary membrane may act as an impedance to oxygen transfer from the alveolus to the pulmonary capillary. This defect in oxygen diffusion responds to oxygen therapy in a manner similar to ventilation perfusion inequities. Therefore, it is extremely difficult in the clinical setting of acutely ill patients to differentiate primary diffusion defects from inequities in ventilation perfusion ratios. However, it should be remembered that the pathophysiology of each is distinctly different and should not be confused. And we completed chapter 4. There we go. One chapter completely done. See? Chapter 4. We did it. Thank you so much for the likes and subs. Reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We just completed chapter 4. Highest heart love. When we reconvene, it will be chapter 5. Clinical evaluation of the pulmonary system. So we just completed physiology of external respiration chapter. We complete. We do it again. Or 4. That was chapter 4. Thank you so much. I will see you soon. It's a new day, right? I will see you soon. Can't wait. After chapter 5 is chapter 6, and chapter 6 is oxygenation. Big time, big time. Thank you so much for reading with us. We shake it up in the world reading books here on YouTube live from the light here in LA. Drink a love water. Take us out. Thank you. I love you. Ooh. Love you. I love you. I love you. So good. I wish you have a majestic day. Happy Tuesday. Remember, we have to be grateful and thankful for all we have now and all that is coming to us. So grateful and thankful for all I have now. And all that's coming to me. I deserve it. I love you. So thankful and grateful. Thank you for reading books. Highest heart love to the book lovers community. I love you so much. All of you out there making a change in the world. I want you to have a wonderful, wonderful day. Highest heart love. Thank you so much. Yes, yes, we do it. We do it the right way. Honorable. Thank you so much. Everyone in Bangi. Love to all our elders, our mothers and fathers, our family and friends, our sons and daughters. I love you, Bubbles, so much. You know I do. see you soon. Thank you for reading books with us. Peace.